Well, welcome everyone. Thank you for joining us on your Tuesday afternoon or morning, wherever you are in the world right now. But thank you for joining us for this Tribal and State 90-Day Partnership webinar. Next slide, please. Before we begin, I would like to note that the views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the U.S. Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide, please. My name is Kaylee Small, and I'm an enrolled member of the Chickasaw Nation in Oklahoma. I have the privilege of serving as a Tribal Technical Assistance Specialist for SAMHSA's 988 Crisis Systems Response Training and Technical Assistance Center that is operated by Altarm. Today's webinar is hosted by SAMHSA's 988 CSR-TTAC, which provides training and technical assistance support to states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care. Along with our partners, W2 and Change Matrix, who have extensive experience with crisis services and technical assistance, the CSR-TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system. The goal of the Crisis Systems Response TTAC is to support a crisis care system that is integrated, sustainable, and aligned with evidence-based and evidence-informed practices. Next slide, please. Today's webinar is a training and educational opportunity for shared learning among tribal and state partners engaged in 988 and crisis response work. There will be time for questions at the end of the webinar, where we encourage you all to engage for information sharing, planning, and problem solving around partnerships between tribal and state entities. Next slide, please. Today's webinar is intended to explore the importance of creating strong and meaningful partnerships between tribes, tribal organizations, and state governments to better serve American Indians and Alaska Natives who need access to the crisis continuum of care. There are many studies and statistics that show extremely high suicide rates among American and Indian and Alaska Native people, and tribes and urban Indian organizations are typically under-resourced to provide crisis services themselves. We will discuss case studies and examples of best practices ranging from data sovereignty to state legislation that led to a tribal-specific call center operated by and for American Indian and Alaska Natives. After attending this webinar, attendees should be able to understand the concept of tribal sovereignty and self-determination while exploring the implications for partnering with Native tribes and tribal organizations, and the role of urban Indian organizations in providing services to American Indian and Alaska Native people living outside of tribal areas. Understand the mutual benefits of state and tribal partnerships when supporting tribes, tribal organizations, and urban Indian organizations to develop tribal-specific and clinically effective services in the crisis continuum. And lastly, identify specific actionable strategies between your state, the tribes, tribal organizations, and urban Indian organizations within state boundaries. Next slide, please. Now let's take a moment to ensure that everyone in the audience is ready and comfortable with the technical aspects of the webinar. We'll walk you through the webinar interface, including how to submit questions and other technical information. As you will see, closed captioning is enabled for today's webinar. We also have American Sign Language capabilities enabled in this meeting, and they are spotlighted for you as well. If you need tech support during today's webinar, please send me a chat message and I will address it for you. And lastly, if you have questions for our speakers during the presentation, please enter them into the Q&A area. The questions will be sent directly to the presenters and moderators. Please note we will not be monitoring the chat for questions, but do encourage you to chat amongst yourself if you'd like to. If you have any information you'd like to share in the chat, please feel free to do so. Next slide. This webinar has been planned by SAMHSA's 988 and Behavioral Health Crisis Response Coordinating Office and the CSR-TTAC. Before we move forward, I want to thank the esteemed leadership of SAMHSA's 988 office. This webinar has been supported by Interim Director John Palmieri, Division Directors James Wright and Joel Mace, as well as each member of the 988 team. Unfortunately, SAMHSA is unable to attend today's meeting due to current communication guidelines. However, they remain committed to leading and supporting this important work. Now let's get to the reason we're all here today. I would like to turn it over to my colleague, Andy Hunt. Andy, can you please introduce our speakers for today?
Thank you, Kaylee. My name is Andy Hunt. I'm a member of the Lumbee Indian Tribe of North Carolina, and I currently serve as the Tribal Technical Assistance Specialist for the CSR-TTAC. Today, we have a privilege of being joined by a panel of state and tribal subject matter experts within our field, and I'll take a moment to introduce our presenters to you now. Phoebe Blout is employed with the Fort Peck Tribal Health Project's Garrett Lee Smith grant as the project director. She developed and implemented the only suicide prevention department on a reservation in Montana. She also developed and implemented the first ever crisis call treatment center in Montana for tribes. And the Fort Peck Call Center is the only operational crisis center line for Native Americans within the tribe, within the state of Montana. Now, Jackie Gittens serves as the Crisis Intervention Specialist and Director of Voices of Hope. Voices of Hope is one of 3 centers that operates the National Lifeline 988 hotline in Montana. They serve 36 counties, which includes 7 Indian reservations, and answers over 9,500 calls a year. She has presented at over 35 various training and workshops to over 1,800 participants. She continues to do educational outreach and answer the hotline, helping those who are feeling overwhelmed. And this is a priority for her. So our next slide. Charlene Pula is the Tribal Behavioral Health Director at the Albuquerque Area Southwest Tribal Epidemiology Center, or ASTEC, the Sowing of Seeds Wellness Program. She is Hopi and Tewa and Navajo from First Mesa, Palaca, Arizona. For the past 20 years, Charlene has provided counseling and suicide, substance abuse prevention services to Native communities in the Southwest. Stephanie Paz is Tigua Indian from the Isleta del Sur Pueblo. She holds an MPH in health, behavior, and promotion from New Mexico State. She is a program evaluator at the Albuquerque Area Southwest Tribal Epidemiology Center, and she has extensive experience with Indian health boards, including NAIHB, Northwest Portland Area Indian Health Board, and Albuquerque Area Indian Health Board. And she focuses on policy, health campaigns, and evaluation. So next slide. As you can tell, we have a slide. We have a whole bunch of superstars on our panel. So next is Andrea Holly. She's 988 Tribal Response Grant Manager for the Choctaw Nation. In this role, she plays a crucial part in fostering partnerships and collaborations between Choctaw Nation and Certified Community Behavioral Health Clinics, or CCBHCs, in various state and local agencies. Her work focuses on enhancing support and services for tribal communities in crisis, furthering her dedication to making a significant impact on mental health. Additionally, Andrea oversees the behavioral health staff at the Choctaw Nation Emergency Room and is working to streamline an effective referral process to connect patients with appropriate inpatient and outpatient services. Johnny Green serves as the Director of Crisis Services with Lighthouse. With Lighthouse, he has worked and supervised every aspect of the Lighthouse crisis response system. Johnny has worked in the behavioral health field in some capacity for about 15 years. He currently serves on the 988 Tribal Work Group with the 988 Tribal Grantees, working to improve access to behavioral health services across Oklahoma for First Americans. Our next slide, and our final set of panelists. From my old stomping grounds in the Northwest, Shane Lopez Johnson is an enrolled tribal member of the Toloadi Nation, Sorry if I said that wrong, Shane. He is the Thrive 988 project director at the Northwest Portland Area Indian Health Board. Shane and his team are working to inform and educate Northwest tribes about the 988 and suicide crisis helpline to improve intertribal and interagency communications. He believes that culture is prevention and that tribal-based practices play a key role in suicide prevention. Amanda Whitecrane is from the Northern Cheyenne Nation. She grew up in southeastern Montana, and she is the Director of Tribal Services at Volunteers of America, Western Washington, supporting the Native and Strong Lifeline and Native Resource Hub team members. She is passionate about providing trauma-informed services rooted in cultural practices and frameworks, such as gathering of Native Americans, providing mental health services to Indigenous communities in different capacities for over 15 years. Amanda's a licensed social worker, associate at the Washington State, and graduated with her MSW from UC Berkeley. So with that, as you can see, we have a group of superstars. So we're going to pass it over to Phoebe and Jackie to get us started. So let's go, Phoebe and Jackie. Thank you.
Thank you. Next slide, please. So I'm going to talk about understanding the concept of federally recognized tribal sovereignty and self-determination act. And that really actually a good example of that would be the self-governance 638 contract. And what a 638 contract is the right for tribes to administer programs and other agencies under their direction. And I can give an example of that, which is at Indian Health Services, which is under DPHHS. We have tribal health projects that are 68 contracts of HHS, IHS services, and they do provide medical and also other limited and more educational efforts on health and welfare. The implications for partnering with Indian tribes, I have three that I feel that are really pertinent to this. One is that tribes are not under criminal and limited civil jurisdiction. The other one is dual policy and protocol process involving state and tribal laws. And so, as mentioned earlier, we are a tribal crisis line call center in the state of Montana, and we are on a reservation. We have partnered with 988 Voices of Hope in hopes of becoming under their licensure, which means a satellite office. And in doing so, we would have to, in order to complete this endeavor, we would have to follow dual policy. We would have to follow what is under their guidelines through the state, and then we would also have to go through our tribal laws and how that works. This will be a timely process. We are still working on it. This also involves attorneys and also the tribal council. And then from the state level, Jackie will speak about that later. But through tribal sovereignty and self-determination, we really don't have to complete an application because we have a right to govern ourselves. We just present our resolution to the council, and then the council will hear what we are going to endeavor to do, and then we either get support or we don't. But I will like to say that our tribes is fully supportive of our tribal crisis line call center. Next slide, please.
So I'm Jackie Gittens. We serve as Voices of Hope 988 Crisis Line, one of three centers that covers that. But providing services outside the tribal areas becomes a challenge because sometimes we don't know what services maybe the tribe or the reservations individually hold, and that includes formal and informal resources. We work closely with Phoebe to input those resources. We also have a program in the 211, and we've updated a lot of our resources into it. We've put bullet points, as you can see, in our 211 resource database so people can look it up, but they can also call 988, as we'll get 211 too. we're acting as a bridge between the 988 crisis line and the reservation itself. We want to be able to build those the trust that is absolutely imperative on the tribal's members, connecting with us, and the trust that we have in Phoebe's organization and the tribes, and that they will gather. We use their crisis line a lot as 988 comes in. If we can't resolve an issue, or the person that is on the 988 line may need more individualized, more hands-on services that we can't provide, we used for Phoebe and her crisis line to help that individual and guide them through. I've been to many different, actually 2 different conferences in the past year on the reservation, explaining what we do and trying to build that trust so that we can provide services not only for those people that are on the reservation, but maybe they've moved to a different city and are a member of a tribe, and what organizations and what things they can help them as well. Next slide.
So in doing that, we provide tribal specific services. So we are still in the process of creating a tribal specific services manual. And it's really more considered an etiquette manual. It's not about tribal spirituality or any type of ceremonial practices. It's mainly about etiquette, how to speak with someone on the reservation, or if you have that familiarity with them, just that connection, and just to be really kind, and also a history of the Fort Peck, Assiniboine, and Sioux tribes, so that the staff of 988 at the Voices of Hope can have an understanding of our callers who do reach out to them. And that will happen, because currently right now, if you call 988, it will go to the Great Falls Voices of Hope. And so that's why we are developing this tribal specific services manual, so that they are able to capture this information and then build a rapport with the callers who call from our area. And this is then a training to Voices of Hope to the staff that are answering the calls. And again, we hope to have this manual completed June 30th. And as Jackie has mentioned, she has been to 2 conferences of ours. We had a suicide prevention awareness conference in September, and we've also just had a 988 Tribal Mental Health Summit. And 988 has always been invited to that in order to provide information to the community, give them a face to look at, and she's developing that rapport with them. And then also we provide evaluations at the end of our conferences to see how and why and if 988 is viable in our area. So we take the data from that. And we also offer at our crisis line call center traditionally specific activities, including ribbon shirt making, moccasin making, medallion making, beading, and drum making. And this is to callers who we have built a rapport with, who may not want traditional counseling or want to see a counselor, but this is a good way to build that rapport with our callers. And eventually the goal is for them to become familiar and also trusting, so that before you know it, they are talking about what's going on while they are doing activities. Next slide, please.
So we have some actionable strategies that we're working on in order to ultimately have a satellite office right there on the reservation in Wolf Point. The first step was to build an MOU with Voices of Hope, and that has been completed with them. It's pretty basic. There is no funding that is back and forth. It's just an MOU. This is what we're going to do and try to provide for you, and this is what they're going to do to provide for you. One of those things was a location for a call center and to get it staffed. Phoebe had funding and was able to get a location for the call center and has it staffed. And we have a good relationship with them. We have their number, they have ours. and working back and forth. A lot of this entails building, like I said before, the building of the relationships in regard to trust and understanding. We've done that through meetings and conferences in the community. I know sitting here, I am not a member of any tribe, but I have two children that are. And so that it makes it very apparent to me, and one of them lives on the reservation, that this is something that is needed. And I try to look at what are the needs and what's the differences. A lot of times it's not much different than the smaller communities of the Western world. That we don't need to do maybe specific things that are tribal related, except for the tribal specifics of what their values are, what their meanings. I think in each gender, there are different things that they believe in, that may help them, that maybe isn't the norm for Western folks or for another tribal specific region. So completing those tribal specific service manuals, we have a goal to get that done by June 30th. That will ultimately serve as a guide in getting those tribal specific services manual for each reservation that we cover here in 7, so that when somebody calls in and acknowledges us that they are from a specific tribe, we can then look at that manual and familiarize ourselves with what are their beliefs, what are there's going on with them, so that we're not interacting, we're on their level. Meet those people and meet those callers where they're at. Ultimately, the goal is going to be have her center accredited by the tribe. We know that part of that's going to be being a satellite office for us before it can ultimately be their own 988 call center. And we will do and have done everything we can, from providing manuals that we already have in act that they don't have to reinvent, that they can look at and reformat and make those specific to their region and their tribal specific region. Next slide, please.
Okay, thank you, Phoebe and Jackie. Let's go ahead and I'll turn it over to Charlene and Stephanie.
Good afternoon, everybody. Can you hear me?
We can.
Okay. Good afternoon, everybody. I'm going to be talking about our 98 project with Stephanie Paz, and we are going to be discussing some of the evaluations that we've done with some of our tribal subawardees. Go ahead and go to the next slide. It's so nice to see some familiar names in the chat. There's 196 participants. Those of you who are from New Mexico, hello, it's good to see you. What we do at the Albuquerque Area Southwest Tribal Epidemiology Center, known as ASTEC to most folks, there are 12 tribal epidemiology centers nationwide, and we are one of them. And our parent organization is Albuquerque Area Indian Health Board, which has been in existence since 1977. And then ASTEC came into play in the early 2006. And so we serve 27 tribes in the Albuquerque IHS area. If you go to the next slide, I can just show them the map, and then I'm going to have you go back. So those tribes are 8 northern, 10 southern. We have Zuni down south. So those are the 19 pueblos in New Mexico. 2 Apache tribes, Mescalero, Jicarilla, 3 Navajo bands, To'Hajiilee, Alamo, and Rama. And then in addition, we have the pueblos down south, Isla del Sur, where Stephanie is from, and then the 2 Ute tribes, Southern Ute and Ute Mountain in Colorado. So that gives you a bird's eye view of like the number of tribes we serve. So if you go back to the former slide, please. So what do we do at ASTEC? We provide high quality research, surveillance data, training, to improve the life of American Indians and American Indian communities. We primarily focus on behavioral health, healthy aging, injury prevention, and chronic disease prevention and management. The activities we do with our tribal partners is conducting community health assessments, creating databases to monitor project outcomes, to create progress reports for the communities we serve and track any program activities. We also assist tribes with their evaluation activities or supports they might need, and technical assistance relating to behavioral health and health and aging, prevention and chronic disease prevention. Most of you are aware of the Youth Risk Behavior Surveillance Survey that CDC administers, but we in New Mexico call it the Youth Risk Resiliency Survey. And so our organization helps disseminate, administer that survey to schools that have a high rate of American Indian and Alaska Native students. And so they aggregate the data. And if you ever want to know about the data, we have fact sheets on our website that you're more than welcome to download and use for presentations. Go ahead to the next slide. And then the next one. And so what is New Mexico? What is New Mexico made up of? Well, we have beautiful landscapes. It's a nice time to go fishing here in the summer. But if we're talking about demographics, our population is 2.13 million folks here in New Mexico. We are referred to as a minority majority state, whereas we have a high population of Hispanic, Latino population, as well as Native American, Alaska Native, American Indian, about 11%, Latino population, about 48%, and then white population is 35.2%. So we like to be referred to, or you'll hear our legislators refer to New Mexico as a minority majority state. We can go to the next slide. So our governor, Michelle Lujan Grisham, this is her second term serving as governor, and she has a strong relationship with the tribal leadership, tribal partners, tribal communities, and she has created, well, not under her, but the New Mexico Indian Affairs Department is a cabinet level department here in the state of New Mexico. And what that means is they provide opportunities, supports for tribal leadership when it comes to legislative policy from the state, federal level, when it comes to funding opportunities, when it comes to access to resources. They are a strong advocate and a liaison, if you will, to tribal leadership to ensure they're getting this information. So what really helps with New Mexico as far as funding opportunities and programmatic action that's occurring that's going to impact tribes is the State Tribal Collaboration Act of 2000. I wrote it down, 2009. That was established in 2009. And what that means is it mandates state agencies such as the New Mexico Department of Health, or even the Indian Affairs Department or the Behavioral Health Services Division in New Mexico, to make reasonable efforts to collaborate with tribal leadership, tribal government, so that they're aware of opportunities that are occurring or actions that are occurring that they need to address that will have any tribal implications with communities, tribal communities. And so that has really served as one conduit to create that relationship building, nation to nation building that we discuss. And this has been a collaboration act that's been in existence since 2009. So with our governor and the State Collaboration Act, when it came to the 988 call center, tribes were informed this call center was going to be in existence prior, like a year to two prior. So they really started to build that information for tribal leadership so that they can act upon it, ask questions. And as most of you know, in rural communities, we have these gaps in where you can't get cell service, right? And so if you're ever on the res, at least in my res, there's a certain hill we all go to where we can get good reception. And so tribes were able to ask, how are you going to ensure that our tribal members have access to 988 services? And so they really started talking about how they were going to address that. We also have tribal liaisons in each department under the state that are there to ensure that they're giving information to tribal leadership, tribal governments about any activities that are occurring under that department. Next slide. And so at Aztec, what we really want to make sure we're doing is honoring self-determination. So we have a listserv because most of the programs that are under Aztec and our parent organization, AAIHB, they have worked with one of the 27 tribes in some capacity. And so this everybody list has at least 1 to 5 members we've worked with in the tribal communities. And when there's a grant opportunity and it's something we want to funnel out to the everybody list, that's what we do. And we ask them, do you want to go in on this funding opportunity? And if the tribe does, then we assess community readiness. Do they have the workforce? Do they have the capacity to do it? And more than likely, they always do. So we go in on that grant with them and they become a tribal subawardee. So that's what happened with the 988 grant is we have 8 tribal subawardees. And one of the initiatives was to do a community readiness assessment that our team assisted with and that Stephanie Paz wrote up the findings. It was a lot of work. I think Stephanie wrote a book because she wrote about 500 plus pages on these findings because it was 8 tribal communities we worked with. And so one of the great things about the work with Aztec and our tribal subawardees and our tribal partners in general is this relationship building because AAIHB has been in existence since 1977. And then with Aztec serving 27 tribes, they've been in existence since 2006. So we've built these long-term relationships, partnerships with tribal communities. The other presenter talked about trust. We have that embedded trust with our tribal partners. And so when this opportunity came about, it was easy to get a response within a timely manner. And one of the things we did is we reached out to the New Mexico Crisis Access Line, or actually they reached out to us and said, hey, I heard you guys got this 988 grant. We want to make sure we're capturing the numbers appropriately. Can you start attending these quarterly meetings or monthly meetings to share data? And Stephanie's going to talk about that data here in a minute. But what was really nice is we started to develop these screening questions for folks who are Native, tribal, calling the 988 center to ensure that we're capturing good information. And then the 988 call center was trying to access speakers, Native speakers who spoke the Native language to go ahead and address some of the current concerns the callers had. So if the individual was Navajo, could they connect this person to somebody who spoke Navajo fluently? If the person was Tewa, could they get a Tewa fluent speaker to talk to this individual in crisis? So our New Mexico 988 Crisis Access Line really worked hard to ensure that there were services and language services for those Native callers who spoke their native language. And so I'm going to go ahead and forward it to Stephanie. That's it. Thank you.
Thanks, Charlene. Can we move on to the next slide, please? Okay, so I'm unsure how many of you in attendance are familiar with SPARS, that's SAMHSA's Performance Accountability and Reporting System. And basically what that is every quarter we are to capture data on the 988 Tribal Response Grant and report it back to SAMHSA. So as Charlene mentioned, we are the awardees of the 988 Tribal Response Grant. And then we have about 8 tribal communities who are the sub-awardees of our grant. And part of that is collecting 2 what are called indicators through SAMHSA, 2 indicators every quarter, just so SAMHSA is aware of what tribal subawardees are doing with the 988 Tribal Response Grant and how they're applying it for crisis response in their reservation. So the first indicator that we ask tribal subawardees to report on is known as workforce development. So each quarter we ask that our tribal subawardees provide us the number of people and the mental health and related workforce trained in mental health related practices. So this can be representative of a tribe's EMS, first responders, behavioral health staff, and so on, who might have received mental health and related workforce training, such as ASSIST, QPR, mental health first aid, and so on. Then the second indicator that we request of our tribal subawardees every quarter is that they provide us the number and percentage of individuals receiving mental health or related services after referral. So this all goes back to our partnership with New Mexico 988 and Colorado 988, since as Charlene mentioned, we do service 2 tribal communities in Southern Colorado. And I'll get more into why this information is relevant. So we ask that tribal subawardees report how many people are receiving services after a 988 referral. And maybe this is something that you in attendance have encountered, but sometimes the data is very limited into how many people are receiving, how many tribal people are receiving services from 988 and referred by 988. So to fulfill this gap in this data, we have asked our subawardees to make sure that this number reflects the referrals from 988. And part of that can be having it in the referral form when a client comes in that they say, oh, 988 referred me. So I'll go more into the relevance of this information. Next slide, please. So from our tribal subawardees, we do collect a certain amount of data from them, but most of the data comes from our states. And this comes into play with our 988 call center partnership. So 2 of the indicators that SAMHSA asks us to report on every quarter is screening. So how many individuals were screened for mental health, and referrals. How many people were referred for mental health services? And we use this data along with the data that our tribal subawardees provide us to figure out the access. And again, there's still gaps in the data here because it is very hard to track how many people specifically, my apologies, thank you. How many people are contacting 988 and actually receiving services in their tribal community? So as Charlene mentioned, we do have a partnership with the New Mexico Crisis and Access Line, New Mexico 988, and each quarter they will report to us how many chats, texts, and calls they received that quarter from self-disclosed Indigenous callers. So people who disclose as Indigenous. And then they also provide us how many of those people who self-disclosed either through chat, text, and call for that quarter were provided referrals to a behavioral health agency, a hospital, and other services. So that is our partnership with New Mexico Crisis and Access Line, or NMCAL for short. Then we have a partnership with the Colorado Behavioral Health Administration. And I'll go more into that throughout this presentation, but at the moment, data is limited from them when it comes to demographics. I know that they're working with an amazing call center at the moment to start recording those demographics, but at the moment, it's been limited. Next slide, please. As Dr. Pula mentioned, in 2023, we did have NMCAL reach out to our then program evaluator. Her name was Mary Costello. She's still with Aztec. And at the time, Wendy Linebrink Allison, she was a former New Mexico 988 system program manager. And Wendy had reached out to our program evaluator, as Charlene mentioned, saying, hey, I saw that Aztec received this 988 tribal response grant. How can we partner with you and increase maybe access, care, and our visibility for your tribal communities? So at the moment, that partnership is still going strong between me and Claire Carmoni. She's a new New Mexico 988 program manager. And as mentioned, they provide us quarterly data on how many self-identified Indigenous people contacted New Mexico 988. Part of this partnership that's new is including zip code specific data as well. So a barrier we encounter is sometimes tribal affiliation isn't gathered when a self-disclosed Indigenous person contacts 988. So it can make it hard to possibly connect them with services to their tribe or report back numbers that, hey, probably this person from tribe X called, but that zip code specific data can help us potentially overcome that gap or barrier to see if this person called from a specific tribal community. And as mentioned, this data helps us fulfill the data that SAMHSA requires of us for our New Mexico tribal communities. Next slide, please. And then last but not least, but we do have our partnership again with the Colorado Behavioral Health Administration. This came into fruition in 2023 as well between me and Callie Bowman. She is a 988 Enterprise and Crisis Line Program Manager. As mentioned, at the moment, they're collaborating with Solari Crisis and Human Services to improve Colorado 988 contacts and collect demographic specific data. And then we have bi-weekly meetings with them to discuss how the Colorado Behavioral Health Administration can support the initiatives of tribal communities in Southern Colorado, whether this be through financial support, trainings of these tribal communities, helping them with communication products, or making communication products a little bit more tribally relevant to those Southern Colorado communities, and then advocating for them at the state level. And Colorado Behavioral Health Administration has been a great partner with us and our Southern Colorado tribal communities. So very grateful that we work in 2 states that honor tribal people and are just great advocates for them. Next slide. Thank you all so much. If you have any questions for Charlene and I know we have a Q&A section, and then there's also our email addresses. And again, my apologies about the background noise.
All right, now we're going to transition to 2 of my favorite new friends from Oklahoma. We've been working, had the opportunity to work with them over the last year with our Policy Academy, and they're doing awesome work in the state of Oklahoma with all the tribes. But we're going to focus specifically on some great work that Choctaw has been doing with their CCBHC and the probably the first ever Children's Urgent Care Recovery Center affiliated with a tribe. So without further ado, I'll let you guys talk about this great work.
Hey, good afternoon, everybody. Glad you guys are here. Glad to be a part of this. Just before we actually get started, Andrea, I thought it was interesting. Jackie and Charlene both mentioned trust. And, you know, that was a huge thing for us as well, is developing that trust between the state and the tribes. You know, you first invited us to come and speak when you went to the Choctaw Nation, and we came over and spoke to, I don't know, about 200 of your people who were there in behavioral health, and they didn't believe us when we said that we would do what we would do. And it took a lot. I actually gave my wife's telephone number out by accident to those 200 people that contacted me. I don't, do you remember that? Yeah. And so we had, that was kind of fun for a while. We got that fixed, but they learned that, yeah, we are going to do what we said we were going to do. And so, you know, one of the things I think that's important when you begin to work with the tribes, those of you who are representing state entities, is that you keep your word and you do what you say you're going to do, no matter what it costs you. That's how you begin to build trust and build collaboration. And Andrea and I had worked together before, and so we knew we could trust each other. We had to bring our organizations together, and eventually what we did was begin the process of putting together this Children's Urgent Recovery Center. We've done other things too, but this is the big thing that everybody talks about. So anyway, Andrea, I'll let you jump in and start.
Well, Halito, which is hello in Choctaw. I just want to thank everyone for having us here. When I came on as in this position as program manager, I knew nothing. Without the help of our Tribal 988 work group, our state liaison, Josh DiBartello, Tony Stetler, who was the director of Solari at that time. Without them, none of this would have happened. I mean, they have been supportive, they have been full of knowledge, and have, you know, helped build this, you know, along the way, and have supported and encouraged us. But one of the things I noticed when I came to Choctaw Nation is, like Johnny said, there was no trust in our state facilities, and our tribal members had been let down. So I wanted to make sure that whatever collaboration that we built, it wasn't going to do harm to our tribal members, A. And B, it would increase the number of beds, not only for our tribal members, but also for our community as a whole. I think one of the beautiful things about this collaboration is that we carry the responsibility together, as opposed to just putting it on either the tribe or the state. So through lots of conversations and draft reworks on contracts, here we are. We finally opened in November of 24. Next slide, please. A lot of this.
Yeah, go ahead.
Yeah, you go ahead.
Well, Andrea and I, we talk over each other sometimes because we're excited about both of this. But, you know, one of the things that we have in Oklahoma, as you guys probably do in your states, is a huge need for children placement for inpatient. But we also knew that a lot of those children who went inpatient probably could be handled at a more appropriate level if they did some outpatient crisis at a URC, a urgent recovery center. Perhaps we could keep them out of, you know, going into the hospital. More than half of the children had been evaluated and placed under emergency detention. We weren't even able to find beds for them, and they were staying in the ERs for 3 and 4 days, sometimes waiting for a bed to become available. And you know, we saw this need, and you know, we began working together to try to figure out how we could serve the Choctaw Nation, and they could help us to alleviate the problem that the state of Oklahoma had.
Yes, we are ranked 48th in the nation for access to mental health services. So we definitely needed this partnership and to open our URC. There's also a significant rise in suicide completion, suicide ideation, and self-harm in the state of Oklahoma, which also further validated the need for this partnership. Next slide, please. We've already discussed a lot of this. Choctaw Nation and Lighthouse share a lot of the same core values. It's very important. Mental health is very important. Tribal sensitivity and holistic hearing is at the forefront of our care for our tribal members and community members.
Yeah, and it's important too that you do share the same values. I've had to learn a lot coming on to the 988 tribal workforce group that I was invited. Andrea, I guess, nominated me to be a part of that, and it's been one of the better things that I've been involved with. I've grown quite a bit, learned a lot of things that I didn't know, assumed too many things, and I've had to change how I think and better understand the Native American people that I interact with every day and how they really felt about the state and their commitment. We have the same kind of values that the Choctaw Nation has in taking care of people, making sure that people are addressed in a manner that is appropriate for each of them individually, and not just treating someone, you know, across the board the same way. And so with that, we were able to collaborate together to build the Children's URC to be able to meet the needs of the tribal citizens in Choctaw Nation.
Next slide, please. So from the tribal perspective, this partnership represents more than just a project. It's more about a shift in how we work together to meet the needs of our tribal members and the community in a way that's rooted in respect, trust, and shared responsibility.
One of the things that we discovered is not everybody in Oklahoma did things, other CCBHCs exactly the same way we did. And that some of the tribes, even besides just the Choctaw tribe, have felt like they weren't being received in the same kind of manner that that we were receiving them. And I found out that this was true, and I have been working too on the back end with people at the state trying to get this changed. I think it needs to be changed, but it is a change in thinking, and that's where I was getting to. It's a way of seeing this differently. It's not two different entities, two different kinds of people. We're one group of people who may look different and maybe even use different language and things like that, but we're all human beings, and every person needs the care and the treatment that is respectful to them in a manner in which that they can use it to bring healing to themselves. And we work hard to try to make that happen. And it is a different way of thinking. You can't make this work between your two entities if you're not willing to change a little bit on how you see things. One of the things that we did here, I'll jump in again, Andrea, sorry. But when we were building the Children's URC, you know, one of the things that, you know, we already had the staff, we had the training, we had you know, we had everything ready to go. We just didn't have the money. And Andrea said, well, hey, we've got the money. And so we thought, well, let's make this work, right? Let's bring this together. And I don't think, Andrea, we realized the impact of what we were doing.
No.
I didn't, you know, and then everybody says, oh my gosh, you know, tribes have never done this with the state before. And gosh, we didn't know. We're just taking care of people. That's what we want to do. And this is what happened.
It was wonderful. I think one of the greatest surprises that came from all this is because Lighthouse didn't share this part, but they included signage with inspirational messages and Choctaw language in Choctaw language inside the adolescent URC building, so that the tribal members that do receive services from them feel a piece of connection when they walk into that building.
Mm-hmm. That's right. And I will say, before I forget, we're actually getting ready to expand. You know, right now we're able to serve 3 children and their caregiver. We're going to expand by the end of this year to double that in size to either 6 to 7. And we purchased a building and been able to work again with the Choctaw Nation to create another great space. And you know, when the state came in and did an inspection the other day, Andrew, I haven't got to tell you this, you know, they said, you know, this really feels like a home on the inside here. And, you know, we really worked hard to make it feel that way so that it doesn't feel so institutional when a family comes in. And we have been able to, we did the numbers the other day. We've served 90 families since we opened. And I think only 5 have had to go inpatient from our facility. We've been able to keep those other 85 out of inpatient facilities. So it's been very successful.
That is awesome. Next slide, please. Johnny, I'm going to let you have this first part of that.
Okay. So we're located in Durant, Oklahoma. And that is down on the Red River in southeastern Oklahoma. We do assessments, we stabilize, we treatment plan. We use the TBRI model. I don't know if y'all are familiar with that, but it's a systems-based model and it's family-based, and we're very excited about it. Actually, are going to be working with the Choctaws, sending folks to be trained and become TBRI trainers. And that's coming up soon. We're excited about that. But we have psychiatrists, therapists, nurses, counselors, family support specialists, peer recovery support specialists working with the families and helping them to, you know, hopefully trust each other a little bit more. That's what we've been talking about today. And we want to focus when we're working with someone from the Choctaw Nation or the Chickasaw Nation. We have, you know, kids that come from there. We want to be sensitive to their tribal needs and how they want to be not treated, I guess, but how they want to follow up with their care when they leave our place. They don't have to follow up with us for outpatient. That's not certainly something that we push. We can now have 3 consumers and 1 family member per consumer. The law in Oklahoma is that they have to stay with them 24 hours. They can't leave their children there by themselves. And we don't just serve the child, we serve the family. And they can get an iPad to be able to talk to us after they leave if they need to. They can always come back if they want to. And there's, I just said, we're going to be sending them to TBRI training here pretty soon. So I don't know, Andrea, are you guys sending folks too? I can't remember.
We will be sending 2 from Choctaw Nation Behavioral Health, and then 2 from our ICW and JSU departments on the Choctaw Nation headquarters side, so that they will also have access to that training for the youth that they assist in those roles.
Yeah, and the continuity of care is very important.
Continuity of care, whenever they need that crisis treatment, they can go in, receive that care, come out and receive the same modality. So I think that will definitely act as a post-vention treatment.
Yeah, we feel like that's a very important part of what we're going to do. Next slide. So you should see the picture of us. Right there in the center is Chief Batten. I think that's right, isn't it? It's real small. And then next to him with the scissors is our CEO, Jessica Fowl. And then, you know, various people. I guess Andrea and I are in there somewhere, I'm sure. But many people came together to make this happen. You know, the grant writers, and Andrea can tell you more about all of that. I'm more of the on the ground, feet on the ground guy. So.
Oh yes, we had well, Durant PD. They came to celebrate with us. Our leadership in behavioral health, and then standing next to Jessica, that is our assistant. No, that's not. That's our tribal council member from this area. Next slide, please.
Yeah, this is real important because, you know, if we do this, what do we hope happens, right? And so we don't want to just do things to do things. We want some good outcomes. And so these are some things that we anticipate will happen. And of course, we have seen is reduced ER visits. And so instead of them having to take the child to the hospital for evaluations, they can come straight to us. And it saves them money, saves the resources for other folks who may need that. So we feel like it's a better use of those resources. And it improves our crisis response services across the Choctaw Reservation, as well as the state of Oklahoma, because anybody from the state of Oklahoma can come to us. And again, shifting the stereotypes of suicide and mental health issues within the community through education and outreach. And, you know, those will take time. You know, they're not going to happen overnight, but we expect to see these things change in the future. Next slide. Yeah, sorry. Go ahead.
We, as for us at Choctaw Nation, we're looking to expand services and increase outreach by working not only with Lighthouse, but other departments within Choctaw Nation. One example of this is through this partnership on the behavioral health side. One of the department heads on our government side reached out to Lighthouse, and they now have is it a partial bed contract?
Yes, we're still in negotiations. It's not finished yet.
So they're in negotiation for a partial bed contract, so that if one of our tribal members needs a bed, that will be guaranteed. Is that how that works?
Yeah.
I'm new to one. Okay.
Yeah, that's right. Mm-hmm.
As we build these partnerships and collaborations, and we improve the education and outreach, I foresee that there will be a lot more development in the area of not just crisis care, but also mental health in general.
Yep, I agree. Next slide. So in doing this, we got about 2 minutes, Andrea, but there are barriers to overcome. Limited funding, shortage of specialized staff, the stigma around mental health, lack of transportation. But I think the one is the mistrust between state and tribal leadership. That's the one that has to be overcome first. in order for the others to dominoes to begin to fall, where state entities and tribal entities can begin to collaborate and work together to accomplish care for everybody, not just their own individual, people, but seeing it as all as a human. Anyway, I could get off on that. I get on my soapbox. I'll not do that. We don't have time.
All right. One of the barriers that I see for Choctaw Nation is funding to open up our own. I think in order to be able to provide this care, we will have to work together.
Yep.
And that's it.
That's it. Thanks, Andy.
All right, so next we are going to transition to a couple of my other favorite people that I've known since before 988. And I'm really proud of both Shane and Amanda. I knew both of them when they were just young pups doing some good work, and now they're fully grown, doing great work that you guys can all learn from. And so really excited to have them as part of this presentation. A lot of you guys know about the press for option when you call 988 and how that was implemented in the state of Washington. So they're going to tell you about how they did that. And I will toss it over to you guys. Go ahead from the Great Pacific Northwest.
Thanks, Andy. I appreciate the intro, and man, what a great panel to sit back and listen to. I kind of found myself like lost in thoughts around these just great concepts and strategies that we have across Indian country. And so first, I guess I'd like to say Delahant, which is just, hello in Talawan, saying, what a great opportunity to sit here and represent the Northwest Portland Area Indian Health Board. I have the opportunity to work for our 988 Tribal Response Project. The board here in the Northwest serves the 43 tribes of Oregon, Washington, and Idaho. And our tribal response grant that we have through SAMHSA has 11 sub-awardees. And so I'd heard kind of a couple of people talking about that. With a sub-awardee, we have contracts that allow us to have intertribal and interagency collaboration that allows us, I think, to address gaps within kind of our tribal communities in being able to identify areas in which 988 could either be more implemented or talk about where those strategies that we can use with cultural connection to be able to implement within those communities. So I'm excited to kind of be here and talk a little bit about that. I think one of the main processes that we have is really trying to improve the referral and process time that we see within the Northwest. Amanda will talk more specifically about her program within Washington, but having Oregon, Washington, and Idaho, we have 3 different call centers that we work with. And so being able to work with them and their unique aspects that they have within their communities and counties to be able to work with tribes, refer back to tribal services, follow up. Those are all things that we work with at the board to try to improve on. Part of that process that we've really identified is just the understanding of what 988 really looks like. I think there's a lot of misinformation that's out there. And I think some of that is around, it being suicide and crisis hotline. And so really letting our tribal communities know that this is a crisis line that can be utilized. You can utilize it through phone or text. You can also utilize it for those that maybe are in crisis but don't want to call, and so you're calling for them. So we've developed a video project plan to be able to kind of help with that information and being able to disseminate, I think, culturally appropriate services and quality of what those look like can really differ depending on each tribal community. So trying to get ads out into some of our tribal newspapers, being on PSAs, but the video project has really been great. We got to partner with the VOA Western Washington Native and Strong to do a spotlight video and a walkthrough, and really we are trying to humanize our crisis call de-escalators, right? And showing that these are everyday people just like us, and that all people call in. We wanted to let people know, you can call in more than once. There's people that call regularly to check in and different things. And so really just having an opportunity to spotlight the great work that they're doing, but also letting people know like this isn't something to be scared of. The media campaign that we have is going to be expanding into this year as well. We have youth that we're going to be interviewing. We're going to do a spotlight video for Lines for Life, which is the call center in Oregon. And we have a elder that we're looking to do as well. And so these again are to show like relatability. We've had really good response to these. We've done 3 already with a veteran and a community member, and then Volunteers of America, Western Washington, Native and Strong. So our hope again is to really create kind of, I think, less stigma around these services that are out there, and we're hoping to do a Northwest commercial as well to take down some of that anxiety about what it is to even call. We've found that kind of the unknown is almost scarier than actually doing it, and so trying to alleviate some of that stress and anxiety about calling. And then we've had a really great opportunity to partner with the Policy Academy that SAMHSA offered, and Washington State has a team that has been put together. Amanda is part of that team, and we are thankful to really kind of have an opportunity, I think, to address gaps again within our system of care that we're looking at. Some of those areas that we've talked about and are working on are going to be kind of like flow charts for our entry levels for when people come in, like where are they going, right? Like what level of crisis are they coming through? 911? Are they coming through 988? Are they being referred through a tribal clinic? And then how do we get them kind of referred back and make sure that they're receiving services that are adequate to their needs? And then I think part of that other thing, piece that I've heard people talk about is data, right? How are we collecting our data and being able to identify metrics to track that will benefit like the services that we're doing so that we can really make sure that we are meeting the needs of our community and our population. And so those have been really great to be a part of. Amanda and I have had the opportunity to partner around meet and greets, which I think are a great opportunity as well for our tribal community to get to know our call centers. And so these are opportunities that go out and invites that go to our tribal community for them to come to an event and have an open platform to share any questions or concerns, to bring up any of those kind of small doubts that maybe they didn't want to ask via email or over the phone, and have that kind of opportunity to share openly. And then, of course, I heard the trust piece, right? The trust piece is really important in making sure that you are following through with what you're saying you're going to do, that you have the tribes at heart when you're thinking of what this looks like, that you're looking to do something that's going to benefit them as a community. And sometimes that looks different in each community. And so making sure that you're taking the time to get to know what that looks like, going out and doing site visits and things. So it's been a great year and a half, and moving forward, we're excited to see what the next year and a half brings. And just very, very thankful to be a part of the committee that we have for the Policy Academy and this 988 Tribal Response Project. And luckily, I get to partner with Amanda, who has all of the wonderful information. And then I just get to sit back and relax. So, Amanda.
Yeah, thank you, Shane. Pivawana, Pivashiv, thank you so much. I feel so honored to be part of this panel and presentation. It's just so beautiful seeing the work that's being done across the US and talking about crisis work, because it's super important. And like Shane was saying, just destigmatizing, asking for help is the core of what I'm so blessed to be part of with behavioral health in Indian country. So if we could go to the first slide. For Native and Strong Lifeline, excuse me, we launched with the passing of the House Bill 1477 and advocation of Tina Orwell and Vicki Lowe from the American Indian Health Commission. And we took our first call in November of 2022. And really, Volunteers of America Western Washington did a great job in centering peer-led programming with the hiring practices of really being that core piece of having tribal affiliation and connection with the community. So proud to say that we are all 100% team members tribally affiliated. Calling 988 and option 4 will connect you with our tribal crisis counselors. They'll also be greeting you with their tribal affiliation in the beginning so that there's that less stigma of you are getting connected with somebody from our Native and Strong Lifeline team. You have the ability to, like Shane was saying, to connect with our Native Resource Hub, which Volunteers of America, Western Washington had prior to Native and Strong Lifeline, and really came from the transformation of Medicare around trying to improve that tribal behavioral health system of referrals, and that connection of what about tribal people? Where do we kind of connect, and where are those systems built in? So as shared in the presentation, we are that someone to call, and we really hope that if there isn't somebody to call within the person's own behavioral health tribal system, that we can fill that gap, because we are operating 24/7 and really want to be that support when there's nobody else to answer that call, and to be that in between of, let's get you to your provider, but let's leave a message and we can be here to support you in the meantime. Next slide. So as I mentioned, we started with a team of 20 of crisis counselors, along with our wonderful coordinator, Mia Click. And then we are expanding. We have now currently a team of 32 for our phone lines. And then we are looking at launching our chat and text program here very, very soon, here in the summer. And we're really excited about that team expansion. So we are now, with that team, looking at over 54 members, including our leadership team. And so we're really happy about that. It's really amazing to come to work every day and be with others that really care about this life-saving work. So we prefer applicants that have knowledge of cultural practices and resources specific to their tribal communities. So all of our members are licensed through the Department of Health, and really we encourage that peer-to-peer licensing as well through the state. Our educational levels are from high school diploma GED to master's degree level counselors, and we're really happy to be supportive of any mentorship towards higher education. All of our counselors are onboarded with the services. An overview of for all the call center counselors, are their very first training schedule to do is to review our land acknowledgement and kind of foundational work that we do with Native and Strong Lifeline, and how important it is, along with our virtual personas to interact with. We have two currently now, Emily, and I'm forgetting the name of our other persona, but tribal members that they can interact with over the phone, and voice interaction, and also chat. So we're really happy about developing those out and integrated with all the counselor training. We have a training specific about historical trauma and what that means in different areas, and specific to Washington State, of what was mentioned before, of different rural areas that might not have that ability to have landline connections, or excuse me, just within that emergency response area, and some of those struggles. Um, Overall in counseling, we're really push the importance of asking somebody if there are any identities that they'd like to be considered when they're looking for resources. And that's what we really, really lean into with the ability to warm transfer to our line, or to connect with our line, is we can connect you with those different tribal resources that are specific, and through the Native Resource Hub really help close that loop of, yes, they got connected with a provider, they're uh, they're getting that in-person response that they need at that time. Next slide. And so as Shane mentioned, this is huge in our partnership with Northwest Portland Area Indian Health Board. Of tribal input and partnership is everything. I think with making sure that we're following crisis protocols, making sure that we're understanding some of the barriers that our crisis counselors can be trained on or understand in navigating and looking for resources, and just how we can be of best communication and support throughout that entire process, so that there aren't any gaps, that there isn't any sending somebody is a place where it might not be the best fit. So I think that we really spend a lot of time making sure that we're understanding a lot of the processes and building out those partnerships as we grow and go into our year 3 of really how do we make sure that we are developing MOUs and data agreements with tribes, so that we are really closing that, understanding where those gaps are and providing that data to improve it. So we received so many technical requests, and that's what my best part of my days is, sharing about what we do and talking about the expansion of different crisis lines and what support that we can provide through Native and Strong Lifeline. We'd love to help with sharing out any of our trainings. Mia Click has developed out a training manual of going in depth more of our operations in partnership with Suicide Prevention Resource Center, and that toolkit should be released here this upcoming year. So we're so excited to share out and understand how we can connect here from Washington. Our call volume, our average is around 550 calls per month, I think was from last year. Our call volume increased from 2023 to 2024 by 48%. And as I mentioned, we're really excited about our Native and Strong chat and text line, especially in reaching the youth demographic and understanding how we can connect with youth mobile crisis units and continue our work with tribal DCRs and designated crisis responders. So we're just really excited about that expansion and what it'll mean for us supporting Washington State. Next slide. And this is our contact information. Please feel free to reach out. This is our team. And we really are excited to still be, I think we still have 10 openings. So if anybody is really wanting to see how to apply for our positions, I'll drop that information in the chat as well. But thank you.
Great. Thank you, Shane and Amanda. And thank you to all our speakers. We really appreciate you taking the time to show your support and share your expertise with the 988 and crisis systems community.